I'm from the University of Stirling. My name's Emma Coles, and I'm going to talk about context, which might seem a little abstract after everything else, but bear with me. So, if the answer is 17 years, then what is the question? And it's frequently stated that it takes an average of 17 years for research evidence to turn into clinical practice. But maybe the question that we should be asking instead is, what's the reason for the time lag? And it could be argued that the reason is that insufficient attention is paid to context. So, what do we mean by context? Context is one of those words that you encounter again and again without anyone actually offering a useful definition. It's something of a catch-all word, which you might mean all the things in the situation that are relevant to meaning in some sense, but we don't quite know what they are. Or it's the set of circumstances that surround a particular event, or the interrelated conditions in which something exists or occurs. So as you can see from these, if you can see them, I'm sorry they're so small, contextual information influences our understanding of a situation, and so human action can be rendered meaningful only by relating it to the context within which it takes place. And the meaning and consequences of a behaviour or an action will vary with the context in which it occurs. So context is everything. So what I'm going to talk about today is, why does context matter? What do we mean by it? Why do we need to understand it? And why is it relevant to you today? I'll look at various definitions and levels and dimensions of context. I'll look at the role of context in implementation, in practice, and look at contextual factors in terms of barriers and enablers, and discuss some examples. And we'll look at how you can assess your local practice context using the Context Assessment Index, which I think hopefully you have a copy of, with the aim of planning ahead and making your context more supportive for change. So why does it matter? Because, as we know, best evidence does not always lead to clinical practice change. Promising evidence-based interventions that may be implemented effectively in one setting don't always transfer to other settings, or maybe they won't be sustained over time. This is known as the implementation gap, so that many interventions that are effective in health services research, they don't translate into meaningful patient care outcomes across multiple settings. So again, the usual explanation offered is context, which varies between settings or changes over time. So the importance of context in shaping effectiveness of knowledge implementation has long been recognised, but understanding and overcoming the contextual barriers at the local level is crucial, and that can lead to highly effective implementation. But until recently, or relatively recently, there's been very little guidance as to which aspects of context are the most important, whether they can be modified to enhance the impact of quality improvement interventions. But the field isn't standing still, and the thinking around context is rapidly advancing, and new developments are emerging. But what has it got to do with maternal and child health? At the inception of SISCC, one of the key themes was to understand the role of context within implementation and quality improvement. And the SISCC proposal defined context as factors varying by locality that have been shown to influence improvement. And within the SISCC, improvement programmes are being planned and delivered in a way that mitigates for contextual barriers in advance, where possible, and taking account of local knowledge to enhance implementation and improvement strategies. So in your case of improving infant feeding and maternal infant attachment in neonatal units, this has meant reviewing and presenting the best evidence, as you've seen, then scoping out knowledge among a wide and diverse group of stakeholders, yourselves, about what's feasible in a real-world practice setting. And this scoping includes assessing local readiness to change and engage, and an exploration of the contextual barriers and facilitators, which you've been doing already. So in the stakeholder consultation, the survey that some of you would have taken part in, certain contextual factors were identified that are likely to impact on the ability to implement new practice. Issues such as attitudes and beliefs, staff training, social support networks and resources, facilities, organisational factors all came up. And these are backed up by research, such as this review of the barriers and enablers of the adoption of kangaroo care. The review, again, very similar to what you said, identified a number of themes: buy-in, social support, assistance to perform kangaroo care, the time to perform kangaroo care, and issues within the context of the health system regarding resources and service delivery. So, to answer the question, what is context, it might be useful to look first at this publication, Perspectives on Context, which was a series of think pieces commissioned by the Health Foundation Key researchers in the field of context in quality improvement were asked various questions, and one of the questions was, how do you define context? And at its most simplest, that could be everything other than the intervention. But that is too simplistic. To take it further, you could define it as a set of characteristics or unique factors that surround a particular implementation effort. But it's not just the backdrop to implementation, it's a set of active and interacting variables, everything that interacts, influences, modifies, enables or constrains an intervention or a new practice. But as Paul Bates stated there, it's still massively misunderstood, so time to flesh it out a bit. Apologies if that's too small to read, I will go through it. But various definitions, and they've changed or sort of been fleshed out over time, expanded over time. Starting in 2002, context was described as the social, political or organisational setting. But then it's not just the setting, it's culture and leadership factors too, and I know that culture was discussed this morning. It's the organisation, the community, political decision-making, the researcher decision-maker relationship, public participation, and interventions or new best practice. They're a product of their context. They're affected by factors related to individuals, teams, relationships, institutions, organisations. And more recently, the bottom, in a review of the evidence to practice gap or the implementation gap, context was conceptualised in terms of barriers and facilitators, which I think is something that you can relate to and will find useful to think about context in that way. So again, the thinking about context has evolved over time. To take in things like the key features of the environment in which the work is immersed, which can be meaningful to the success, failure and unexpected consequences as well of an intervention or a new practice, as well as the relationship of all these to all the stakeholders. And the importance of particular or individual context features might depend on the infancy or maturity of an intervention or a new practice, the stage of its implementation, the level of its implementation, is it national, is it hospital level, is it unit level, and the type of intervention or best practice that it might be. And context incorporates all the various contributors to the improvement effort: staff, patients at the clinical coalface or the clinical microsystem, the quality improvement team, organisational structures and functions, and the wider triggers and motivators and influences within which we're all operating. So just to illustrate this about the layers and dimensions, there are multiple layers and dimensions of context which are overlapping, interlinking. They change over time constantly. So there's the inner and out, we'd call the inner and outer, within the organisation, and also what's external or what's more distant. Hard and soft factors. The hard factors would be structural factors, and the soft ones cultural, psychological factors. The levels of the system or organisation, from the macro right down to the micro. And at the heart of all this is the clinical microsystem, which is you, I guess. But we also understand this as a process that's shifting, dynamic, fluid. So think of context as a process as well, is what I'm trying to say. It's all of these things, but it's a constantly moving process. So in other words, it can be difficult to pin down, but hopefully you see where I'm going with this. So if it's dynamic, interventions obviously evolve and change as well during implementation, and then they change the context then changes them. Perceptions, roles and practices change over time, and they have a bearing on delivery of an intervention or best practice. These changes might take the form of changing attitudes towards the intervention among practitioners, participants, researchers, patients, changes in skills and confidence of practitioners. Because, as this quote says, increasingly it's recognised that the context in which the practice occurs has an impact on the user, professional and organisational outcomes. But the context, as I've said, also has an impact on the intervention itself, and it can sometimes be very difficult to separate the two as the intervention becomes part of the context. So there's some more quotes to illustrate this, because the distinction between intervention and context can then become very unclear in some cases and be blurred. In fact, you could say there's an overlap between the intervention, its implementation and its context. So the definition of a boundary between improvement and the intervention itself can be arbitrary. And it can be difficult to separate context itself from an improvement intervention because of the interactions over time between the two. And even where interventions can be separated from their healthcare context, the elements of a context that might influence the outcome of an intervention might not be straightforward to identify and might be almost impossible to control for or standardise. So interventions may blur into or depend on elements of context for their effectiveness, or some are shaped or co-constructed by aspects of context. I hope this is all making sense, it's not too abstract. But to try and relate it back a bit to what you were doing this morning when you were considering feasibility, say, and to give some positive examples of how contextual factors might play out in practice. Because enablers and barriers to implementation would arise at multiple levels of healthcare delivery, patient, provider, group level, organisation, policy, or whatever. So to just give some examples, the availability of key people leading change is often crucial. The existence of local champions, supportive leaders, what we might call change agents. A supportive organisational culture is very important. Effective managerial and clinical relations. Cooperative inter-organisational networks between and within healthcare organisations and between healthcare and other organisations. Simplicity and clarity of goals and priorities, but also finally the fit between the change agenda, the intervention or best practice, and the setting. In other words, are you doing it already or are you working towards it? Because the fit between the intervention and the context is really crucial to success. So how does all this fit with what we're doing today? What we're trying to get you to think about is how to build in context from an early stage and how to manage it. So we want you to think about how to make your practice context more supportive for change by using known evidence of context alongside locally identified barriers and facilitators. And what you can do is use the context assessment tool, which I'll come to next, to assess contextual barriers and enablers so that you can plan for these barriers and enhance the enablers. So, have you got a copy of this, the Context Assessment Index? It's a list of statements, and I think there's a table as well. Might just be helpful just to have a brief glance at it if you've got it in. I think it's coming around now. Yeah. Because there are many, many frameworks and tools and models and theories to look at context, and among these there are tools available to measure and assess context in practice settings, of which this is one of them. This is the Context Assessment Index, which was developed by Brendan McCormack and colleagues at the University of Ulster. It's a diagnostic tool so that practitioners can understand the contextual factors in their clinical area. So it can be used to determine readiness for change, readiness to implement new practices, but it can also be used to raise issues, particularly contentious ones, in a more neutral and impartial way. So it defines context as the setting or environment where people receive healthcare services. And 3 elements have been identified that form that context to ensure that there is person-centred practice, culture, leadership and evaluation. And the index assesses these 3 elements and enables healthcare professionals to assess the context within which care is provided in their clinical areas. So if you just briefly have a look at the list of context statements on the first page, for example, using this, you might be able to get a sense of whether your context values staff education and training or whether it doesn't. Does it value some aspects of practice over other ones? Is the management structure inclusive or not? So you're thinking about things like that. And if you look at table 1, that gives examples of weak and strong indicators for change in relation to context, culture, leadership and evaluation. So that, using that will give you an idea of where your unit stands in relation to those indicators and which ones you might want to address to strengthen it. So some aspects of your context might be better than others, and these are the ones that you want to look at in relation to implementing new practices. So this goes back again to thinking about the barriers and enablers that are part of your context, why they might exist and what you can do about them. So finally, just come back to what I said at the beginning. Context is everything. So I think the key messages or the contextual things to think about that I'd like you to take from this is, as you know, a wide range of contexts impact on your work, from the wider policy context to the services and practice context, the physical environment, the context of relationships between staff and patients, staff and parents, and so on. Think about which aspects of context are most relevant to you, which do you want to prioritise and address. And you may have touched on some of these aspects when you completed the questionnaires and when you considered actions, strategies, barriers and enablers. So think about context from your own point of view as an individual within a wider system. Look at your individual context, the levels within it, such as the team or organisational level. And bear in mind the dynamic nature of context as it changes over time, the strengths and weaknesses of your existing practice, and the factors that are internal to each site and the external factors that affect your practice context. And finally, just think about what actions can be taken to address and overcome any contextual barriers. because context is everything. Thank you.
Thank you.